So this is the scout view. Why is the scout view so important? It shows us the thickness of the cuts, and also the cut is taken from which level to which level is also seen in the scout view. This view is also known as a gantry view or the pilot view. So now let us start with all the anatomical structures. So in this cut, we are seeing the nasal bones. This small structure is the nasal bone area. This is the frontal bone. This is the right frontal sinus, which is well pneumatized, under left frontal sinus, which is a bit opacified. In the next cut, we see the two nasal bones separately, and the frontal sinus on either side are well pneumatized. This is the interfrontal sinus septum, which lies in the median plane inferiorly, and it may move to either side, deviate to either side as it moves posterior superior. So this nature of the frontal sinus is known as the scalloping nature and is lost in the mucocele. Now this part in between this thick bone that is being seen in the picture is known as the frontal beak. This thick bone is known as the frontal beak, which lies along the floor of the frontal sinus, anterior inferior to the floor of the frontal sinus. So these three so here we can see this is these are the two nasal bones. This is the frontal beak area, frontal sinus. Nasal bones, frontal beak area, frontal sinus. In this third picture, we can see there is no frontal beak. So this area is known as the frontal recess. This is the difference between frontal sinus and a frontal recess, though both of them look similar. When the frontal beak is lost, that area is known as the frontal recess area, and this sign is known as this change from this to this is known as M sign or the T sign. Inferior turbinate. In the coronal cuts, I've shown the superior attachment of the inferior turbinate. As we know, the inferior part of the inferior turbinate overhangs the inferior meatus, but the superior part has three processes. The first process is the lacrimal process, which gets attached to the lacrimal bone. The second is the ethmoidal process, which gets attached to the uncinate process. And the third is the maxillary process, which gets attached to the maxillary bone. So this is the axial scan, whereby through and through we can see the inferior turbinate. This is the sagittal view, where we can see the inferior turbinate. So septal tubercle, it is a mucosal thickening in the anterior part of the septum, which is the remnant of the vomeronasal organ and contains erectile tissue. So now this is the Agger nasi cell. What is an Agger nasi cell? An Agger nasi cell is the most anterior ethmoidal cell, which pneumatizes the frontonasal process of the maxilla. So these are two different cuts. So why I have given these two? Because as per definition, an Agger nasi cell is any anterior ethmoidal cell that lies anterior to the attachment of the middle turbinate. So here we can see only the inferior turbinate. The middle turbinate is not yet visualized. So this is the Agger nasi when the middle turbinate is not yet visualized. This is one way to identify the Agger nasi. In this one, here we can see the middle turbinate, but it has not attached to the cribriform plate. The first attachment is to the cribriform plate. So as it has not attached yet, any cell anterior, seen before the attachment is also an Agger nasi cell. So now in the axial cut, we can see the Agger nasi cell. This is the Agger nasi cell. This is the frontal sinus. There's a frontal recess. So Agger nasi cell forms the anterior boundary of the frontal recess, which is very clear in the sagittal cut. So the relations are anteriorly frontal process of the maxilla, posteriorly infundibulum, laterally lacrimal bone, and inferomedially uncinate process. So what happens if there are large Agger nasi cell? So for example, if we have a large, this is the Agger nasi cell and this is the frontal recess area. If we have a large Agger nasi cell, it will narrow this frontal recess area. Now in this picture, we can see that this is the lamina papyracea. This is the orbit region and this is the lamina papyracea. So as we all know, lamina papyracea is a thin plate of bone. So if this Agger nasi cell is infected, the infection can pass through this. There are few dehiscences in some cases of lamina papyracea. So this infection can pass through the dehiscences into the lacrimal sac area. So what is the importance? Sometimes the ophthalmologist may not get any cause for epiphora and he may send the patient to us. So what we do, we take a CT scan and also endoscopically, we might see an infected Agger nasi cell which causes lacrimal sac infection leading to dacryocystitis. So this is one important clinical thing that we need to remember. Now, what is an isolated Agger nasi cell? In one side, if we have a single Agger nasi cell, sometimes it has been seen in few patients, they complained of pain behind the eye and there is tenderness on the medial palpebral ligament. So endoscopically and CT scan, we see an isolated Agger nasi cell.